I would like to welcome you all to Yale Interventional Radiology Grand Rounds. Today, I'm honored to invite Professor Bernhard Gebauer to present some of his interesting and exciting work on ablative therapies for cancer. Professor Gebauer is currently Section Chief of Interventional Radiology, Director of the Virchow campus, and Executive Vice Chair of the Department of Radiology at Charite, Berlin, which is the largest department of radiology in Germany, as part of one of the largest healthcare systems of all of continental Europe, with more than 3,000 beds. Originally from Hamburg, Professor Gebauer graduated from medical school in 1997 from the Free University in Berlin, which is now part of the Charite University School of Medicine, a hospital founded in 1710. Professor Gebauer completed his residency in diagnostic and interventional radiology in Berlin and has been on faculty in Berlin for now almost 20 years. Professor Gebauer is an international expert in interventional oncology and has introduced several novel methodologies of tumor ablation, including CT-guided percutaneous high-dose rate brachytherapy of liver cancer. He has authored and co-authored more than 200 manuscripts, reviews, and book chapters on the topic of interventional oncology and image-guided therapy, and has lectured across the globe. More importantly, Professor Gebauer is a key part of the Yale Interventional Oncology Research Laboratory and a long-standing friend of our group. Along with Julia Shapiro, he co-directs the very successful medical student exchange between Yale and Charite, which has been going on for many years and has given more than 20 German medical students the opportunity to do research in our lab at Yale. We now welcome Professor Gebauer, at least virtually, to give a lecture on one of his major areas of research interest. His talk is entitled Ablative Cancer Therapies, Interventional Oncology Meets Radiation Oncology. Interestingly, we have a very close relationship here at Yale with therapeutic radiology, and as many of you know, radiation oncology has become a separate medical specialty dating back to the 1970s, just like interventional radiology has been in a similar situation in the past decade. There are many, including myself, who believe, given our similar development in patient care needs, there should be even more collaborative efforts between our two image-guided therapeutic specialties. So with that, I'd like to welcome Professor Gebauer to give us this talk. Thank you.
Dear David and dear Julius, thank you very much for the invitation and for the opportunity to join the research which we are doing at the Charite with Yale. Obviously, it would be much more interesting to visit you in person and give the talk in person, but due to the pandemic, virtually is a nice alternative as well. So I would like to talk about how interventional oncology and interventional and radiation oncology could work together. And as you already mentioned, in Charite University, the so-called CT-guided brachytherapy was developed, and I will, during my talk, very much focus on that area. There are a lot of other areas where interventional radiology and radiation oncology could work together, but I will try to focus a little bit on that field and show our actual research and our actual developments about that. These are my financial disclosures. I would like to talk about starting with brachytherapy. What means brachytherapy? Brachy means that we try to give the source of radiation near to the place where to the treatment area. There are different ways to do that. The technique we are using for interstitial brachytherapy is afterloading technique. That means you have a small catheter, and over that, the source is implanted into the tumor. I'll show you it later on how it actually works or how it was developed, what we're doing today. There are, of course, other ways of brachytherapy, like implantation of seeds. It's very popular, for example, for prostate cancer. And if you have a look at it, then even radioembolization is a form of brachytherapy because the source of radiation is brought very near to the target organ or to the target source. What we are using is afterloading technique, meaning that in CT, we place a catheter right into the tumor. You will see later on about 90% of our treatments is liver. We have some experience outside the liver, but 90% is liver. So usually an afterloading catheter is placed in a CT guidance in the tumor, and then the patient is referred to the radiation shield bunker where the actual therapy starts, meaning the catheter is then connected to a transport catheter and to the source. And the whole thing is controlled by a controlling computer, where we first of all today, together with radiation oncology and radiation physics, doing the treatment plan for this certain patient. I'll show it later on how that works. If you have multiple catheters, they are usually closed at the end, so the source knows where the start point is, and then you can withdraw the source every 5 millimeters. And the longer the source is standing still at a certain position, the larger the treatment area will get. The area of tumor we call clinical target volume, or CTV, like in radiation oncology. And our goal is, with a one-time treatment, that we achieve about 20 gray of the clinical target volume. Obviously, there is some radiation around that area as well. Actually, it is a little, it's also a benefit of that therapy, because in that area could be some minor, small microsatellites, and these are irradiated even with that therapy. But the big benefit is, if you look beyond, let's say, the 15 gray, that a lot of areas of the liver, even in large lesions, could be spared. And so usually liver function is not that big limitation factor for that kind of therapy. We use an Iridium 192 brachytherapy source. It's sealed in a small capsule and connected to a wire, and over that wire it goes into the afterloading catheter. It's gamma radiation, and the half-time is quite long of the source, but the source, is getting out of the catheter afterwards, so there is no radiation that is remaining in the patient, in contrast to a radioembolization. Obviously, the source has to be exchanged every 3 months, because then the radiation is reducing of the source. This is a way the afterloading catheter which we are using. It's a 6 French afterloading catheter. It's closed at the end, and in that comes the source, and you can stop it, as I said, every 5 millimeters. And the longer it stays at a certain position, the larger the area of radiation gets around the source. This is the technical drawing how afterloading technique is working. You have the source, and usually additionally you have a check cable which is coming at the beginning to make sure that the whole way through the catheter is free and that there are no stoppings or kinkings or whatever. The way we are doing this is CT-guided implantation of catheters. For the catheter implantation, because it's an end-closed catheter, as I said, you cannot implant it directly with a CT-guided or with usually interventional radiology techniques. So we are using a regular angiographic 6 French sheet that is placed into the tumor, and through that we place this afterloading catheter. After placing all the catheters, we are doing a CT scan, either with contrast or not, depending on how good the tumor is visible. And together with the MRI images we have in advance, we do it together with radiation oncology and radiation physics. We do the actual plan. In our institution, it's a Brachyvision software which you're using that comes from Varian. And then these catheters, obviously they are numbered, because you have to know which catheter is which. And then it's connected with the drug brachytherapy source over the connecting catheter, as I explained before. Material is relatively simple. You have to have a trocar needle for the puncture, then over an amplat stiff wire. We exchange that to an angiographic sheet. That one has to fit a little bit to the length of the brachytherapy catheter. In our setting, this 23 centimeter long angiographic sheet is working quite good. Then comes the afterloading catheter, and at the end we are closing the whole thing after removing with gel form over the angiographic sheet to prevent bleeding. That is a very simple but very effective way to prevent bleeding. Again, the puncture, and you see, it's no rocket science here, a very simple angiographic material, nothing really special. Obviously, we number the catheters. In our setting, we have the rule that at least 5 centimeters have to stay outside the valve of the source. And if it is that way, then 2 centimeters beyond the sheet will go the end of the tip. You will see it then very nicely on the CT, because that is crucial for radiation. You have to exactly know where the catheter is, and you have to exactly know where the tip is to make an exact radiation plan. Here you see the sheet, that is radiopaque, and beyond the sheet is the air-filled catheter. And here you know exactly where the tip is. To know which catheter is which and to know exactly where the tip is crucial here for a correct planning and a correct treatment. And then, as I said before, it's connected here. That's the way it looks after the scanning, before the patient comes to the radiation planning. Our goal is usually to do a single fraction radiation. We always try to get 20 gray around the clinical target volume, as I said. Sometimes we have to modify that to 15 gray, if there are organs at risk near. I'll discuss that a little bit later. Usually we have no size limitations. We already treated lesions up to 15 centimeters in diameter. You don't have any cooling effects, no heat sink effect like from other ablations. You don't have a destruction beside the catheter placement. So usually, even if you have tumors in a central or hilar position, you don't have a disruption of bile ducts or blood vessels. And obviously, risk structures should be protected. I will explain that a little bit later. Sorry. Usually, this is the way we do the irradiation. Sometimes, if we have the fear of seeding along the puncture tract, for example, for HCC or even for metastatic renal cell cancer, sometimes we do a little radiation even of the puncture tract to make sure that we could prevent seeding, but that is not done regularly. It's done, on a very patient individual scheme. This is the way the closure function. It's very simple. These gel form torpedoes. We have big gel form, and we cut it into small pieces. We roll them. And then we cut off the valve and do then the torpedo closure of the puncture tract. Actually, that works quite well. We don't see very much bleedings after this afterloading procedure. You have to have in mind that we sometimes are forced in larger lesions to even place more catheters. So usually we come along with 2 to 4 catheters, but sometimes even up to 7 catheters are necessary to do the treatment. There is another technique that has been developed in the last years that we give an additional intravenous catheter. If you have an idea of the liver and about the tumors that are very near the venous outflow of the liver, then sometimes it might be beneficial if you have an additional catheter in the vena cava and or in the hepatic segment. For that, we use the bronchial catheter from Varian, and then we go over the transfemoral venous access and place a long catheter with a long sheet. I'll show you an example. This is a case we did just recently. You see patient has a large HCC, it has some ascites, but he has additionally over the liver veins a very large tumor thrombus that is in the right atrium. And in that case, we did place a catheter here, but additionally, we placed the catheter over the veins. And here you see the catheter over the veins. Here's the catheter, and here's the one that was implanted percutaneously. And with this additional catheter, you can then irradiate very nicely the areas along the venous area here. You see that we also have drawn here the esophagus to make sure that not more than 12 grays are coming to the esophagus. And with that, it was very good treated, that patient. You see, comes from March 2020. So we have the first follow-up. Tumor is getting a little smaller, and actually the right thrombus or tumor thrombus is also getting a little smaller. But yeah, it's not, you know, it takes some time till we see a result that is really a significant reduction. But that's very typical for radiation therapy. So usually our indications are maximum up to 5 lesions. You know, sometimes if there is cluster of lesions, then we can even do more than 5. Usually size is not a limitation, location is not a limitation. I would say we need a moderate liver function, meaning bilirubin should be below 2 milligram per deciliter. Coagulation status should be okay. And we allow 1 platelet inhibitor, you know, like nowadays the guidelines give us. I should be, or I say I should be cautious with bilidigestive anastomosis. You know, these patients have a great risk for living or getting a liver abscess. I think the risk of a liver abscess is not as high as with radiofrequency ablation or microwave ablation, but there is an increased risk in this population for developing of liver abscess. So be careful in these patients. Go for antibiotics, and patients with ascites, of course, they have a great risk of bleeding. So usually what we're doing in patients with ascites, we place a ascites drain before we clear up all the ascites, leave the drainage in, and then we do the ablation to make sure that that will not getting any bleeding. And actually with that, it's a very comfortable situation. And additionally, the ascites drainage works a little bit like an indicator. So if we see that there is coming much blood over the ascites drainage, then we know, oh, there's something probably going wrong, and we could go to angiography. As I said, the areas around that, obviously they have some thresholds of radiation. So this was developed of the former as head of radiation oncology here at Charite. So we are looking usually, if we, for example, go for small intestine, meaning small intestine and duodenum, we draw the area where the structure is, and then we look at the dose, which is coming there to 1 milliliter of tissue and to 0.1 milliliter of tissue. And this is our, you know, our threshold, that meaning it should always be below 12 gray per milliliter. And to even see the top of the tip, we also calculate the 0.1 milliliter, and this is 15 gray. And you see that the different organs have a little bit different radiation cutoffs in brachytherapy. I have to be very serious about this. We always try to stay in line with these cutoffs we once defined, but I personally think they are probably a little bit conservative, that meaning that we never saw a gastric ulcer and we never saw an ulcer to the duodenum. So maybe these thresholds are a little bit too conservative. We could even probably go a little bit higher, but at the moment we are feeling very safe with that because, you know, no complication is obviously a very good result as well. If, you know, kidneys are within the radiation field, we draw the kidneys and we look at the volume that is irradiated with a 7 gray. And our role is that not more than 1/3 of the whole kidney volume, taking into account that there are 2 kidneys. So we draw obviously both kidneys. We're looking at the whole kidney volume. And that should not, and not more than 1/3 should be irradiated with more than a 7 gray. And it's the same for the liver. We, if we have a critical volume, that we look at the healthy liver, meaning liver without tumor. And we look that this area is not irradiated, not 1/3 is irradiated with more than 10 gray to make sure that we don't have a liver impairment at the end. If we have very big lesions and we cannot follow these rules, especially in the liver, then we sometimes do the strategy that we treat one area of the tumor first, let's say the upper part of the tumor. We irradiate with 20 gray, wait 8 to 10 months, and then we treat the second volume. And actually that is a very good strategy to treat the whole thing without even giving a liver function impairment. Medication around that, usually we do all treatments with analgesic sedation. So midazolam and fentanyl is done by a resident of interventional radiology. Sometimes if patients like that, we going for ketamine nowadays. General anesthesia is in our setting very, very difficult to get for these patients. And usually it's very time consuming. We try to on a treatment day, on a regular treatment day, we try to do about 4 treatments or 4 patients on a morning. So if we would do them with together with general anesthesia, usually you can only get 2 patients done or whatever. So if there is radiation to the stomach, you can go for pantoprazole, biliodigestive anastomosis. Obviously, as I said before, there should be antibiotics. And if there is a very large radiation volume, patients are shivering afterwards because you have in these very high radiation volumes, sometimes you get side effects. And together with radiation oncology, we decided here to go for cortisone therapy. Biliodigestive anastomosis, as you know, is a risk factor. We actually, at the moment, we don't have a good study looking at biliodigestive anastomosis in patients with brachytherapy, but we are always a little bit cautious. You know, the results here from radiofrequency ablation, up to 50% of patients are getting a liver abscess. So what about the complications? This is a colleague of mine who did a comprehensive review of all the patients we treated within the last 10 years. So we had something like 2,000 brachytherapies. We had no complications in 85% of patients, bleeding in about 6% of the patients, infectious complications in 2% of the patient, and a prolonged pain in 1.5% of patients. Usually, if you have an area which is near the ribs and the ribs are irradiated together with the tumor, then patients could have prolonged pain due to osteoradionecrosis or changes in the ribs. So you have to always have to balance that with the success you probably could achieve. And it was in that review, it was found out that risk factors obviously is the tumor volume or the sum of maximum tumor diameters, and the target lesion site, if it is at a risk structure or neither area structure, and patients with biliodigestive anastomosis. And again, we looked at other cases and had a look at the frequency of tumor seeding, and you see that we found on the imaging later on 25 cases in roughly 1,700 brachytherapies with tumor seeding. So it is a very rare event. It's not very often. You obviously you can irradiate a lot of structures. I will not go into detail of all of that, but I will try to show you, the results we had over the last decades. I would like to start with HCC because HCC is a big topic here in our clinic. We are a big transplant center. We see a lot of HCCs, and a lot of patients are not in an operative state, so they were referred to us. This scheme, this is the actual one where, ablation is meant to be done either here in a stage A or in a very early stage 0. And in stage B, most of the time here, chemoembolization is used. What changed in the new diagram is that they now have a new arrow here going directly to chemotherapy, but that is another discussion. But if you look at the group B here, meaning that every nodule larger than 3 centimeters is already going into the group B. And this are the patients where, brachytherapy is ideally. You have seen that brachytherapy was not mentioned, but the last ESMO scheme here, brachytherapy is recommended because, in Germany, there are some centers offering this technique with brachytherapy. So this is an example of a very large HCC, and you see it's very near to the vena cava. We, as a planning technique, we always try to have an MRI with liver-specific contrast. We prefer actually Primovis to do that. And then we placed under CT guidance, we do place a lot of catheters. With a lot of catheters, and you can better irradiate these large lesions. And here's the radiation plan. And here's another patient with a follow-up. You see this was a tumor, then the irradiation here, or the catheter placement. This was directly after the treatment. The lesion itself is getting in the first follow-up sometimes even a little bit bigger, probably due to edema. And you also see sometimes around it changes because some areas of the tumor have been irradiated, or some areas around the tumor has been irradiated as well. And later on, then you see a shrinkage, but that is much later. This is probably, I think, 8 months after brachytherapy. So in radiation oncology, generally, the shrinkage, it takes a little bit longer than we usually are used to other ablative techniques. This was a very, very difficult case that was referred to me. It was a patient with a recurrent HCC. He already had a biliary digestive anastomosis, and you see the dilated bile ducts here. You see the recurrent HCC. Parts of the HCC were in the bile ducts, and I was asked what to do, so I decided here in that very critical patient to do a marking of the tumor with a little bit lipiodol, and only lipiodol like in a taste, but it was more lipidolization, not an embolization. For me, the biggest part here was to mark the tumor, and then we did here the radiation of the tumor, and also of parts that has been in the bile duct, but we also have drawn here the intestinum that was part of the biliary digestive anastomosis to make sure that there is not too much radiation to that structure. And actually, patient did quite well. This was the follow-up 2 months later. You see the radiation area, and this was then the follow-up 2 years later. You see the scare area. Actually, patient did well about 4 years, and then he had a large recurrent HCC. We tried again with TACE and could stabilize him for another 2 months, but later on, it was not possible to stabilize him anymore. But in that patient, 4 years in this very, very critical situation, we could stabilize the tumor and prevent him from any tumor symptoms. So my colleague, Dr. Colettini, had a look at all the brachytherapies we did. This is an older publication from 2012. He had a look at large HCCs, so these ones that are definitely beyond ablation, so meaning 5 centimeters, clearly in the BCLC-B. And he looked at large, meaning 5 to 7, and very large, everyone over 7 centimeters. And here within 19 patients, we only had 1 local recurrence, getting together for 5% of local recurrence. And here, a very large 16 patients, again, 1 recurrence counting up for 6% of local recurrence. So we have a very, very good local control rate with the brachytherapy with a one-time treatment, even in very, very large tumors. We had also had a look at all the patients. You see the mean tumor diameter is here 5 centimeters, so far beyond the usual ablative indication, more in the BCLC-B. And you see here we achieved a 90% local tumor control rate. So very good results for that. Mean survival here of 29 months with this one-time treatment. This is one patient, the only patient actually where I got an histological confirmation. This patient was in a very severe liver cirrhosis. This is, believe me or not, a liver MRI with hepatocyte-specific contrast. You see all these vacuoles. You see that most of the liver is not taking up here this Primovyst because he has a very severe impairment of the liver function. And you see here one HCC and you see the others. They were treated in 2 sessions because they were so near together, and otherwise we would radiate too much areas around that. And then the patient got an offer for a transplant, and he was transplanted. And the day I recognized that, I called the pathologist and asked him to give me some slides about our treatment. And in that one patient now, we have a histological confirmation about 3 weeks histological status post-brachytherapy, and 7 months after brachytherapy. And you see here, these are, they call it vacuoles here are building up. And this one is only, he called it cell debris, meaning that there are no more nuclei and it's only dead cells and some fibrotic areas, but no living tumor cells within this area that has been treated with brachytherapy. Another very interesting question is about, how is brachytherapy doing against chemoembolization? This is a study of our colleagues in Magdeburg, and they compared in a randomized study brachytherapy versus CTAs. And you see that the majority of patients have been within BCLC-B. And you see, if you're comparing, the survival time to progression in these both groups, then you see that brachytherapy is doing much better compared to a conventional TACE. And that also comes out if you look at the hazard ratio. That is much better for brachy compared to conventional TACE. We try to combine CTAs with brachytherapy. Why did we do that? We tried to, if it is possible, because of radiosensitizing drugs, probably to reduce the dose that is necessary by brachytherapy. Actually, in our first study here, we had a look at a combination only of embolization and the combination of a TACE and brachytherapy, meaning that a chemotherapeutic agent is there additionally. But you see the overall survival is not a big difference. Complication rate is very comparable. So we didn't see any difference. Our hope was, as I said before, radiation to sensitize the region a little bit for radiation due to the TACE in the beginning. The drug that was used mainly here was doxorubicin. Why did we not use the drug all the time? Actually, we started with cisplatin because cisplatin is a bigger radiosensitizer. But then at a certain moment, the crystalline cisplatin came off the market and it was no longer available for us. So then we had to switch to doxorubicin. So 95% of the patients were done by doxorubicin. And if you compare it, the brachytherapy alone without embolization is something like 29 months, as I said to you before. So not a big difference in the combination of both. But we found out that there is some soft effects of the combination. The soft effects are that we don't have a better local control rate, we don't have a longer survival, but it is much easier to place the catheter in CT if we did a conventional TACE before. It's much easier to identify the lesions, and it's much better to achieve a complete ablation in these patients. We have, especially in large HCCs with a lot of hypervascularization, we have seen less bleedings or less, we are not that frightened about bleedings anymore because we're feeling much safer with the embolization in advance. But the biggest benefit for me, because I look at all the follow-up of the patients as well, the follow-up is much easier. The problem is not that, I know how an HCC looks like after CT-guided brachytherapy, and if it is not embolized, then there will be still enhancement, because we didn't destroy the enhancement. It takes months till the enhancement goes away. But many of our patients are getting their follow-up images in other institutions, and all the radiologists are trained, if there is, after an ablation, there is enhancement in the tumor, it is a recurrent disease and patient is in a worse condition. So we're getting back a lot of reports from other institutions where they say, the local recurrence, or, brachytherapy was not effective because there's still enhancement. So, but in these patients, because there was taste before, we don't see that many reports from others coming that, it was not effective. So it's a soft skill, I know, but it makes life much easier if patients are not confronted in another institution with the false idea that there is a recurrent or a non-effective brachytherapy. Very briefly, I would like to show you other cancers where we had a look at. So cholangiocarcinoma, we were investigating smaller and larger, and we found also very favorable overall survival, although it's not as good as we've seen it for HCC. We also looked at secondary liver tumors for example, colorectal liver metastasis, a very large group in our institution as well. You see that we had here a little bit larger local recurrence rate, something like 13%. For me, if you look at it from a radiation oncology perspective, a colorectal is a much more aggressive tumor than HCC. You can see it on the mean survival of these patients, and on the other side, on the higher local recurrence rate. This is again one histological follow-up which I got. This is the area where we treated, and these are these. They called it in the report inflammation cells that are around it. It's another discussion. I don't know if we come to that today, but about abscopal effects of radiation. That is a very interesting thing as well that we are investigating, at the moment. I'll skip that a little bit. We also in brachytherapy had a look in colorectal liver metastasis, had a look if irinotecan is making things better due to the radiation sensitizing effect. There you see that again, the mean tumor local control rate was not that much better compared to brachytherapy alone. Although I would like to show you one patient that has been treated with that very large liver metastasis, first with embolization. You see some gas bubbles here after the embolization, and the next day we did brachytherapy. This was the result later on. Actually, these images come from 2015. I've seen the patient in the last month in our ambulatory or outpatient care. He got an MRI and he's still under local control. So with that very large lesion 5 years later or 6 years later, I think very good result. But if you see overall the patients that we had done in this study, we didn't see that overwhelming effect. Here's another patient where we did the combination therapy with these both. A patient cohort that is treated very often in our institution are neuroendocrine tumors. As you know, liver metastases are very often in neuroendocrine tumors or neuroendocrine cancers. Obviously, it's a very broad variety of different cancers, obviously, but we had a look here at 27 patients with 25 lesions, and again, very large lesion diameter, and again, a very good local control rate. Actually, we see these patients now much more often because our oncologists and our gastroenterologists who mainly take care of neuroendocrine tumors nowadays love this. Here's just one example where I would like to show you what is possible with brachytherapy, and it's not comparable to other therapies. You see a very large metastasis here in the right liver from an ovarian cancer. And I hope you can agree with me that this one is not treatable by other ablative techniques. Actually, it was not resectable at all. So we placed here 5 catheters, and did a radiation, one-time radiation of the whole lesion. In that case, only 15 grays, so not 20. And this was the result, I think, 5 years or 4 years later. Massive shrinkage and only, this scar formation. It's not a resection. It's only, this very high intensive radiation here. Obviously, not all the patients come out that good, but this is just an interesting result. You see, if you see at all primary, secondary tumors, we could achieve quite good local tumor control rate. The only is, colorectal liver metastases are a little bit less. As I said before, I personally think this tumor is much more aggressive compared to the others. We also had a close look on the liver function post-brachytherapy. That is a very important point. If the liver function is getting worse after that, in that patient cohort, we had 70 patients with different tumor types where we did an hepatic brachytherapy. Here's the bilirubin. It's going up a little right after therapy, but then it normalizes again later on at 6 and 12 weeks. We have in the Charite a liver function test that is totally independent from bilirubin and from others. It's a breath test, and with that test, the capability of cytochrome P450 is checked. And you see that here, no change of this Limax test was mentioned. So no worsening of liver function post-brachytherapy. Just very briefly, we also had a look at Hilar position if there are more complications and very central positions. And you see again, very good local control rate, not more complications. As I said, follow-up is very important. If you have, a lot of here small lesions, and do you do a brachytherapy like this here, where you enclose all these small lesions and treat them, then obviously afterwards you have an area which you have treated, which is irradiated, so no uptake of the hepatocyte-specific contrast. And a lot of radiation, a lot of diagnostic radiologists, if they look at this image and at this image, they think there is a tumor progress. So make sure that the follow-up is seen by one of your staff or one of your colleagues who is familiar with the changes after brachytherapy, because it could be confusing for diagnostic radiology, and very soon, or they are false interpreted as progressive disease. Very briefly, brachytherapy in the lungs could be done as well. Actually, these are very old data. Nowadays, we don't do any pulmonary brachytherapies that much. Only very rare cases. Nowadays, more patients are going to CyberKnife in radiation oncology. Here's one example where we had a local recurrence. You see it here, and then there was a second therapy we had. If there are very large lesions that are probably not possible for radiation oncology or for percutaneous radiation, then brachytherapy could be a benefit, like in this lesion, which was treated quite nicely. This was, I think, a metastatic liposarcoma. Here in HCC, again, at a very similar position, and this was a follow-up 5 years later. So it could be treated quite good with a good local tumor control rate. And even difficult positions like this one, you see the patient has been resected for esophageal cancer. It has been irradiated percutaneously. And in the area of irradiation, he got a recurrent disease here right in front of the aorta. And this one was hit by one catheter, and we did a brachytherapy here. And this was the result, I think, 2 years later. Patient, these images are here 7 years old. Patient is still at that position under local control. So even in a previously irradiated area, you could achieve quite good local control here with moderate risk. This is here, again, image from 2016, but he was on imaging in the last months as well. Lymph nodes could be done. It's just, an impression, how it looks like. We did some kidneys as well, where, normal ablative techniques are not possible. Usually in these cases, we embolize them first to make sure that there will not be a bleeding. And this patient here, a very large lesion, so we decided here for brachytherapy, but it's a very, very, very rare cases. So these are, most of the aspects or the results we have from brachytherapy. One interesting thing that should be discussed, or probably could be a part of the discussion later on, is the systemic effects or abscopal effects, as we know it in radiation oncology. Meaning you do an ablation here at that lesion, what is doing with the other lesion. If you look for radiofrequency ablation, then there's some authors propagating that the ablation here results in an upregulation and an enlargement of that lesion. But others say that immune cell activation and antigen presentation will lead to a decrease of these lesions. So this is very interesting. It's very interesting, how brachytherapy could get into that. And just my last slides, I would like to share one patient with you. He had a cholangiocarcinoma, very large one. You see here the vein was already infiltrated, so he was not a candidate for an extended liver resection. So we did an ablation here in 2017. And I missed one image. I'm very sorry for that. He had enlarged lymph nodes in the T2 sequence. They were quite big. And this is the result later after the ablation. These lesions here are decreasing in size. I don't know if these are a metastatic disease or metastatic lymph nodes, but they were now getting smaller. So probably in that patient, we've seen an abscopal effect. These are the images later here in 2019. He has been in our department 2 months ago with still a local control rate. The lymph nodes are almost gone here. So probably it's an abscopal effect. It's open to discussion, but we still don't know. What a pity that we don't have an histological proof in that patient. So thank you very much for your attention. I will now close the presentation. And
thanks,
I'm open for discussion.
Yeah, thanks, Bernhard. That was awesome. The results you have been really great. Before we start getting questions from the audience, which I'm sure we'll have a lot of, I just have a couple of questions. One is, I guess, more of a clinical question, and one is more of a philosophical question. So the clinical question is more about, like, you compared brachytherapy to chemoembolization, but you didn't compare it to Y90, which, as you know, is becoming more and more utilized. And that also has its pros and cons, and because it's also considered a brachytherapy, how do you first, what do you think would be the changes, or do you think there'd be a study in mind that could be done to compare CT brachytherapy versus Y90 in a similar patient cohort?
So the study that I presented comes from Magdeburg, from our colleagues, which we work quite closely together. So they compared CTASE versus brachytherapy, and obviously they did do CTASE because CTASE is a standard treatment for BCLC-B. That was the reason why CTASE was chosen here. Obviously, radioembolization would be a very nice competitor as well, because you can really very super selectively treat HCCs. It would be an interesting study. At the moment, let's say, at least the German perspective on treating HCCs with radioembolization is difficult. We have, after the last studies, we have a lot of difficulties to get reimbursement for HCC treatment with radioembolization.
Do you think there'd be any role in doing a study looking with us, for example, because we do Y90, if there's something like that could be potential. because I think that, not all radiation is created equal. And I guess also the patient selection or population is different, right? Because if you have numerous tumors, I mean, that'd be very hard to treat with brachytherapy, right? I mean, it just seems.
Yeah. As I said, more than 5, usually it's not possible to do that kind of treatment.
Yeah.
But actually doing a study there together would be very interesting. Probably we could start in looking at our patient database and looking for matching patients with similar risk profile, and then comparing the outcome of that. We have very good database, and we have all the follow-up of our patients. So that would be a very interesting aspect. Yeah.
Oh, great. The other thing I think, and we talked about this at the very beginning, before we even went live, was the collaboration with radiation oncology, and how, so when you do these procedures, is radiation oncology standing there with you? Are you doing, like, when you talk about being together, are you doing it that way? And how did the collaboration start? Right? I mean, there's institutions where radiation oncology and interventional radiology are adversarial. And I'm not saying that's good. I'm just saying that that's a fact. And then there's others, like here, I believe, where in your place, where it's very collegial, and you see the benefit of working together. So how did that, like, how did your collaboration start, and how do you determine like what specialty does what part of what procedure?
Mm-hmm. Actually, the separation between radiation or with radiology and radiation oncology took place at Charite in 2005, so not so long ago. So from my residency, I know a lot of colleagues from radiation oncology. So the personal aspect, it's still very close. And usually, obviously, the indication and the placement of the catheters is done by interventional radiology. And but then the planning, usually we doing together with radiation oncology. So I draw in the clinical target volume, I draw the organs at risk, and do a gross planning. And afterwards, a colleague of radiation oncology passes by and have a look if everything is so far okay. But we're working together on other fields as well, not only fiducial markers, which we do placing very, very frequently for radiation oncology. We're working together on other fields. For example, if they place tubes for cervical cancer brachytherapy, then we do the MRI planning for them, or we help them with other things. So actually, radiation oncology really, they love interventional radiology. And one thing that which they love a lot is because they always had, they have a lot of cervical and head and neck cancers. They always had problems with gastroenterology to get PEGs in, because they get late for dates, and it took hours, and probably it was not possible, and so on. And now we offered, since 2 years, we offer the service to do CT guided PEG placement, and they love that procedure. Actually, we have every day we have 2 placements for radiation oncology for PEG placement.
Awesome. So are you actually considered, so in America, in order to use the radioactive material, we have to be considered an authorized user. Okay, and there's a whole process that it used to be that radiation oncologists had to always come down and help us with the delivery. And as you know, it took a lot of time, because if they're not available when you're available, you may just stand around for a while waiting around. That has now since gone by the wayside. But I was just wondering, in terms of your approach, do you have to be considered an authorized user, or in Germany, is it, if you're a radiologist, you're kind of automatically considered an authorized user of radiopharmaceuticals?
No, you have to, I think you have to do about 300 procedures, and then you have a dedicated test and a certificate and so on. Because before that, you cannot use that. alone. But, you know, probably that was not so clear. You know, the placement is done in CT. Then the patient is coming into the patient's bed, and then he's transferred to the rooms of radiation oncology. So the treatment room, of course, because it's shielded, it's a specialized room. It's like a bunker, yeah. It's done in the area of radiation oncology. So it is not a problem. They are around the corner. Even they have the control room together with another machine there. So we're just, you know, getting 5 or 10 meters away and ask them if they could have a look at that. So the collaboration in that way is very close. And we're doing the treatment itself in the rooms of radiation oncology.
Great. So we have 2 questions from the audience so far, actually 3. 2, of course, are from our German colleagues. First is actually from Julius, who I know you know very well. Mm-hmm. And he was just wondering if you could elaborate on the cost per procedure. You know, as you know, transarterial therapy is very expensive and can cost, you know, upwards of 30,000 K or $30,000. So we were just wondering if you have a potential synonymous cost ratio that we could maybe understand.
You know that the German system is working a little bit different. So we're in a DRG system, diagnosis-related group, where, you know, everything material and everything is coming into a certain group. So all the material that we are using is more or less inclusive, or more expensive material makes procedures quite expensive in Germany. This therapy is, you know, quite cost effective because the material we are using is rather cheap. But we spend more money on personnel. We need more, obviously, because patient is transferred, you know, from radiation with the catheters to from interventional radiology to radiation oncology, and obviously a physician has to stay with him. He cannot be, you know, alone with the catheters in the liver, which are possible bleeding source. So we need more personnel. So we spend more money on that procedure for personnel and less money probably for materials that we are using. With the radiation oncology, we have the agreement that these patients are in our own beds. We, as interventional radiology in Charite, we have own radiological beds. These patients are in radiological beds, but we pay for every brachytherapy a certain amount for the usage of the room and of their brachytherapy source to radiation oncology. So that's the way it works in our department. But that is, you know, obviously part of any kind of new negotiations in every hospital, I think.
Right.
Does it answer the question a little bit?
Yes, it does. Two other questions. One is, how long did it take when you first initialized this collaboration with radiation oncology until you treated the first patient? And then what did you find, and with that, what did you find is to be the biggest hurdle?
The biggest hurdle, I think, is to get referrals for that kind of new therapy. In the area where we started, you know, HCC, there were not a lot of therapies available. There was not even sorafenib. The only thing you could do is TACE. You know, besides TACE, no really therapeutic options were available. So it was quite easy to, you know, try to do something new for patients who, you know, would like to have any treatments. That was much easier than today. Today, where, for example, for HCC, so many different treatments are available, and even, you know, chemotherapy is trying to get into BCLC-B. I think it will even get harder to get referrals for the new therapy that is not known by your referring hepatologists. So I think that will be very big problem to get, or a problem to overcome to start that. Collaboration, I think if you have a good collaboration with radiation oncology and you're working closely together, I think that should work. That shouldn't be the biggest problem.
Okay, great. And then the last question, and this is something that we were doing back in the early 2000s, which is endoluminal brachytherapy for Hylokolingia. And at one time, that was considered something that could be really, really useful. Not sure it panned out the way that it was thought to be. But the question is there a role for endoluminal brachytherapy for Cholangiocarcinoma, and how effective is it?
I know that there is a literature. Usually these studies are very, very small patient numbers, something like between 4 and 8. I did probably about 4 patients. All these patients were referred to me from gastroenterology. They had already metal stents in, and they had ingrow of tumor into the metal stents. Actually, I did brachytherapy with a reduced dose with the technique I've shown you. It was difficult to really measure the results because it was not intended to cure the tumor. It was intended to prevent these stents from additional tumor ingrowth. From a gut feeling, I can really not tell you if it really was successful. It's very difficult to treat. And nowadays, this kind of indication is more or less done by radiofrequency ablation that is done over the endoscope. So we don't see that many patients for that indication anymore. And to really treat the tumor, I think you need really high doses. And usually it's hard to achieve that because you have the duodenum next to it, which is very radiosensitive. You have gallbladder, which is sometimes radiosensitive as well. So I would be in doubt if this, if you would like to achieve cure or curative intended treatment, I think it's very difficult.
Okay, well, I wish I could say this was the end, but we do have one question that just got added on. And it is actually the $1 million question when it comes down to it, which I think is important to answer, which is that some cases, I guess, that you showed can, also potentially be treated with external stereotactic body radiotherapy or, stereotactic radiosurgery. So how do you decide to go, how you choose which modality to go when it comes to that?
Usually what I learned from radiation oncology or from my colleagues in radiation oncology is that all the lesions above 3 centimeters, they usually have problems in the liver, especially if there are multiple of them, because then the radiation to the liver is summarizing, and there is a higher risk of radiation-induced liver disease. So we discussed the lesions below 3 centimeters with them, and obviously they are also discussed if not terminal ablation is possible in these. But the others above that threshold are usually then referred to brachytherapy.
Okay, well, thank you so much. I think this was great. I think we had a great audience, a great participation, and I want to thank you again. Hopefully in the future, we can have you come out to Yale. Obviously this is all, virtual these days. But I want to thank you for a great presentation and the audience for their participation, and get back to your cases. Looks like you have more patients to see.
Thank you very much for the invitation, and hopefully to see you at the RSNA. I hope that it is.
Yeah, maybe we'll be in touch for. Maybe we'll do that. I mean, I am serious about looking at Y90 versus that. I mean, not that we do so much of it, but I think that that's really comparing more apples to apples. I think not that it's the same, but TACE versus brachytherapy is kind of apples to oranges in a way, right? Yeah. I mean, one of the things that I'm interested in is the liver function after Y90, because obviously you can get a lot of non-target treatment, and if it turns out that the way the CT guided brachytherapy, for example, is better, then maybe we should rethink our way of doing things in the future.